You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or Alexa, what's my flash briefing? I hope you'll join us.
Hi everyone, this is John Mandrola from theheart.org, Medscape Cardiology, and this is This Week in Cardiology for December 15th, 2023, the last podcast of 2023. We'll talk about FDA approval of pulsed field ablation, a breakthrough in pulmonary artery hypertension, residual leaks after percutaneous left atrial appendage closure, and oral anticoagulation use in low to intermediate risk patients. I want to begin with three announcements. The first is that I made yet another mistake. Can you believe it? In my post-Brazil podcast, I said that we did not have Chagas disease in the United States. Well, Dr. Rachel Marcus, cardiologist in Washington, D.C., medical director of the Latin American Society of Chagas, wrote to tell me that there are nearly 300,000 individuals living with Chagas disease in the United States. 57,000 of them are estimated to have Chagas cardiomyopathy. So I wish that I did not make errors, but I actually am happy to receive comments such as these because A, I learn a lot from them, and B, I'm pretty proud that people listen and take the time to correct me. So thank you. The second announcement is that it's holiday time. This Week in Cardiology, we'll take a Christmas and New Year's break. We return on Friday, January 5th. I wish you all a very, very peaceful time at the holidays. Third, I'm going to have my top 10 stories coming out soon on the heart.org Medscape. In total, the essay is about 2,300 words, which usually causes me a rash, because that's way too long, but I separated into little 200-word blocks, so worry not. I hope you leave a comment on this post and tell me what top 10 stories that I missed. All right, first story today is FDA approves the first pulse field ablation system for atrial fibrillation. The announcement actually came yesterday. The US FDA has approved this PFA system for AF ablation. Now, PFA ablates cardiac tissue by delivering electricity to myocytes. Yeah, think shocks, really. People say PFA applications, but each application is actually a shock. The shock electroporates or creates pores in the cell membranes, and that is how the myocytes are ablated. That's also why PFA is thought to be cardioselective, right? Namely, a cell has to have ion channels to be susceptible to pulse field ablation. Now, the system approved was the Medtronic system called Pulse Select. It's kind of curious because nearly all of my European colleagues use a different system called Farapulse. This is the one that we always hear about when we go visit Europe. This approval was based on a study called Pulsed AF, and it was reported actually at the ACC meeting this spring, and it was simultaneously published in Circulation. Pulsed AF was a single-arm study of 300 patients. The primary efficacy endpoint was freedom from acute procedural failure, arrhythmia recurrence, or antiarrhythmic drug escalation. The primary safety endpoint was freedom from a composite of serious procedural or device-related adverse events. And pulse field ablation was shown to be effective at 1 year at a rate of about 66% of patients with paroxysmal AF and about 55% patients with persistent AFib. The primary safety endpoint occurred in 2 patients. 1 patient had a stroke and another had a pericardial effusion. So the procedure characteristics really, though, from this study were not that impressive, especially compared to European operators who are online and on Twitter bragging about how they can do PFA in like 30 minutes, skin to skin. In Pulsed AF, the procedure time was 134 minutes. LA dwell time was 65 minutes. X-ray time 26 minutes. General anesthesia was used in about 90% of patients. Now, I realize that this was an initial regulatory trial. This was a new system for the operator. There's going to be a learning curve. Surely these times will improve, though I'm not sure we will ever be as fast as the Europeans with their single sticks and 28 to 30 minute skin-to-skin procedure times. All right, two other notable mentions here. Success in eliminating the AFib was about the same as all other studies of AF ablation. That includes cryo, RF, lasers. And that too was seen in the ADVENT trial. Now, ADVENT was an RCT comparing another PFA system to thermal ablation. I recently covered that. That was on the September 29th post-ESC podcast show, and I'll link to that. The other notable thing here is that there were two serious complications in this trial of just 300 patients. One patient had a stroke and one tamponade. I note this because one of the selling points of PFA is safety. So PFA proponents point to its cardioselectivity, which means that PFA is less likely to damage the esophagus. And that, of course, is a good thing. But since esophageal injury is so rare, it's going to be hard to show any significant difference. Now, I have a Google alert set for quote-unquote AF ablation, and it went ballistic this week with the news of the approval. PFA's created a serious buzz in the field of electrophysiology, and I mean, I don't know with certainty, but I expect other systems will also gain approval pretty quickly, and this will be followed by marketing blitzes, maybe even direct to consumers on TV or YouTube. And the thing is, I'm always open to using new technology, especially if it's safer technology, but I'm pretty skeptical of PFA. I recently gave a talk at the Brazilian EP Society. It was titled, quote, "Is PFA a game changer?" And in sum, my answer was not so much. In my arguments, I'll just go over them briefly. The first argument really is efficacy. Really, PFA is not any better than a conventional thermal ablation. I mean, we have oodles of data showing that success rates are about the same. The second argument I made is, what about efficiency? And I argued that, yeah, PFA is going to be a little faster, though the empirical data so far do not suggest it's that much faster than thermal ablation. I mean, I do point-to-point RF ablation, been doing it for a long, long time. It takes me about 70 minutes skin-to-skin, and if PFA lowers that by 10 or 20 or even 30 minutes, a question I would ask my listeners is, how big an advance is that? Do patients really care if their procedure is 70 minutes versus 40 or 50 minutes? I mean, if you go from a 3-hour procedure to a 30-minute procedure, that's a big gain. But going from a 70-minute to a 50-minute procedure hardly seems like a huge advance. Now, the third issue is safety. There are proposed benefits, for potential benefits, and avoidance of esophageal thermal injury is a really big thing. Now, the trouble is that esophageal thermal injury occurs extremely rare, so it's going to be hard to show whether PFA reduces that, because how do you reduce something that might occur at a rate of 1 in 10,000. Now, in the recently reported Manifest observational study, this was looking at the Farapulse PFA. This was 17,000 patients presented by Dr. Vivek Reddy. This was from European centers. There was no esophageal injuries, that's good. No pulmonary vein stenosis, that's good. And there were no permanent phrenic nerve injuries. Again, that's good and consistent with the cardioselective aspects of PFA. Though, regarding phrenic nerve injury, in the ADVENT trial, which was Farapulse PFA versus thermal, there were a number of transient phrenic nerve injuries in the PFA group, and I just wonder how that could occur if this is really perfectly cardioselective. Also, in the ADVENT trial, there was a death related to tamponade, and there were also strokes. So again, this is an invasive procedure with potential complications. And to sum up the safety equation, we may, and I think this is still a big may, be able to avoid esophageal and phrenic nerve injury, but there does not appear to be a decrease in the more common complications such as stroke and tamponade. Now, another proposed benefit of PFA is the ability to do left atrial posterior wall isolation. The left atrial posterior wall is that area between the left and right pulmonary veins. Some experts feel that it should be ablated as well as the pulmonary veins because the pulmonary vein musculature bundles actually extend into the posterior wall. The problem, of course, is that a recent Kaplan study, which found no benefit to thermal ablation of the posterior wall. So PFA may be better able to ablate the posterior wall because the big limitation of ablating the posterior wall with standard ablation is that the esophagus sits right behind the left atrial posterior wall, and it limits how aggressive that we can be with thermal RF or cryoablation. But there is really no data that convincingly shows that posterior wall is an important target. Now that may change going forward when we can ablate it with PFA. Now, another reason I felt that PFA would not be a game changer is cost. I mean, we don't have the cost set out yet. It was just FDA approved this week. But I've spoken with friends in Europe, and one of the main reasons why some of my European colleagues have not started with PFA is its high cost. And of course, the final and epistemic issue with PFA is it's simply another way to destroy myocardial cells. The core problem with AF ablation isn't a better way to destroy myocardium. The key problem with AFib is that we don't understand the mechanisms. Success rates remain very similar to what was reported 20 years ago from Bordeaux, and the problem is that we don't really understand the core pathophysiology of AF. All right, second topic is a possible breakthrough in pulmonary artery hypertension. Now, I had a couple colleagues call me out for not discussing a drug called Sotatercept for pulmonary hypertension. One of them is an insider in the pulmonary artery hypertension space, and he says that this is going to be a big deal. This is not my area, so I report here more as a journalist than an expert. Now, I was doing my year-end review, and I came across a trial called the STELLAR trial, published in New England Journal of Medicine in April, and I'll link to it. Pulmonary artery hypertension is a rare and progressive proliferative disorder of the pulmonary vessels. This results in narrowing of the distal vessels and subsequent pulmonary hypertension. It's not caused by pulmonary disease. The most common causes are A, idiopathic, B, heritable pulmonary artery hypertension, C, pulmonary artery hypertension associated with connective tissue disorder, or also PAH related to exposure to drugs such as methamphetamine, and I had no idea that methamphetamine caused pulmonary artery hypertension. Recent research, like basic research, has highlighted the role of altered signal transduction by members of the transforming growth factor beta superfamily. And Sotatercept is a first-in-class fusion protein. And I am way out on a limb here, but the idea is that the drug slows the proliferative process in the distal vessels. Now, I read the introduction to the STELLAR trial in the New England Journal of Medicine, and the biology is about 100x more complicated than AFib ablation. The point is that the sub-Q Sotatercept seems to work on top of baseline therapy such as prostacyclin and fusion therapies. I also learned that there are 10 FDA-approved drugs for pulmonary artery hypertension currently. The STELLAR trial randomized about 320 patients. These were 47-year-olds. 80% of them were female. The primary endpoint was a change from baseline at week 24 in the 6-minute walk test. And there were 9 secondary endpoints that were tested in a hierarchical fashion. And the good news, the median change from baseline at week 24 in a 6-minute walk test was 34 meters in the Sotatercept group versus only 1 meter in the placebo group, so very highly significant, as 30 meters is considered to be a clinically important increase in that 6-minute walk test. The first 8 secondary endpoints were significantly improved with Sotatercept as compared with placebo. There were adverse events that occurred more frequently with the drug, and these included epistaxis, dizziness, telangiectasias, increased hemoglobin, thrombocytopenia, and increased blood pressure. The editorial accompanying the STELLAR trial was actually quite good, surprising in that it was very strong critical appraisal. Quote, "The trial was enriched for patients with idiopathic and heritable pulmonary artery hypertension, 59% and 18% respectively. These are groups that commonly harbor disease-causing mutations, and these findings potentially increase the likelihood of a favorable response to Sotatercept." Also, they wrote, quote, "Only 15% of patients had connective tissue disease associated pulmonary artery hypertension, less than half that typically encountered in clinical practice." And of course, these comments really speak to the meta applicability that I talk about here often, meaning that trials seem to enroll ideal patients, those most likely to respond to therapy. It's not nefarious what trialists do. They're enrolling patients that are most likely to improve. It's what is done, especially early on in development. You try to sort out a population, some population for which a therapy works. There was also a nice discussion on mechanisms and patient selection in the editorial. Sotatercept works on the balance between proliferative and anti-proliferative signaling, but benefits might also come via other non-pulmonary artery means, such as by increasing hemoglobin and or skeletal muscle efficiencies. Merck, the makers, have noted in the press release that it has received priority review from the FDA for a new biologics license application. And so we're going to learn, it sounded like early in 2024 about this drug. All right, next topic is going to be Peri-Device related leaks around percutaneous left atrial appendage closure devices. The paper in question is a meta-analysis published in the European Heart Journal by a group of authors from Greece. And they published this big meta-analysis of studies that looked at the presence of and complications of Peri-Device leaks around appendage closure devices. The first author is Athanasios Samaras. The paper was making the rounds on Twitter because its top-line finding was that Peri-Device leaks, when found by TEE, or transesophageal echo, were common, and they were clearly associated with future bad events like future thrombotic events, stroke, bleeding, and even death. But when Peri-Device leaks were found with CT scan, they were more common, but they were not statistically associated with future stroke events. And that's important because the message became, don't worry about the recent Swiss APERO Watchman versus Amulet study, which found that about 50% of both groups had a lack of patency or leaks when measured by CT scan. Now, I went and looked at this paper and I found some nuance, and I don't think it reassures us that much about the lack of full closure. So let's look at the results in detail. Here's what they do. They take about 48 studies, most of which were observational, and they include a lot of patients, 62,000 patients. About 1 in 4 patients, 26%, had a Peri-Device leak by transesophageal echo. Right off the bat, that's quite a bit. And it was worse with CT-based left atrial appendage imaging. This showed that patency, when you look at CT scan, was about 55% of all patients have patency. So that's a lot of patency when you look at with CT scan. So TEE-based Peri-Device leaks of any size was significantly associated with a higher risk of thromboembolism. The pooled odds ratio was 2, so 2x more likely to have a stroke if you have a Peri-Device leak of any size. You're also increased mortality rate, 16%, and increased rate of major bleeding, 1.12 or 12%. There was a positive graded association between the Peri-Device leak size and the risk of thromboembolism noted across the TEE cutoffs. So For any peri-device leak of greater than 0, 1, 3, and 5 millimeters, the odds ratios for thromboembolism just go up, right? So 1.82, 2.13, 4.14, and for the largest leaks, 4.4x risk of future thromboembolism. So the worse the leak, the higher the risk. Now, none of this is very new data. We know that. The new stuff comes in the analysis of studies that used CT scan imaging. Here, the authors found that neither left atrial appendage patency nor peri-device leak by CT scan was associated with future thromboembolism. The adjusted odds ratio was 1.45, which is a 45% higher risk, but the confidence intervals go from 0.84 to 2.50. So they concluded, quote, residual leaks by CT were more frequent but lacked prognostic significance, end quote. Now, my comments. The proponents want a free pass here. In other words, CT scans are too sensitive. They don't predict events. But I don't think that's true. I want to go to the actual numbers. When you calculate odds of future events with the TEE-guided leaks, you have tens of thousands of patients in the denominator. You also have many, many, many more events. So this gives you tighter confidence intervals and more confidence in that signal. But when you calculate the risk with the CT scan, you have only a fraction of the patients. We're talking about 100 instead of tens of thousands of patients. And the hazard ratio for stroke for patency by CT scan was 1.45. So like I said, it's 45% higher. But the confidence intervals are wider due to the small numbers of events and the small numbers in the denominator. But again, there is a signal of increased harm from patency with the CT scan. I think it's extremely likely that we're finding a false negative here because we don't have enough studies that image with the CT scan. But I do agree that future studies are needed looking at the association between lack of patency on CT scan and future events. To me, this remains a very big deal, right? Because remember, in the seminal trials with percutaneous appendage closure, ischemic strokes were substantially higher than warfarin. And again, these peri-device leaks, either by TEE or by CT scan, may be the putative mechanism for increased stroke rates in the closure arms. All right, next topic is a topic we're going to talk about stroke rates and oral anticoagulation decisions in patients at low to intermediate risk. These are the toughest patients, right? These are the CHA2DS2-VASc1, the non-sex-related CHA2DS2-VASc1, a person with hypertension, a person with diabetes, a person who is 66 years old. So we know, right? We know CHA2DS2-VASc0, very low risk, don't use oral anticoagulation. We know when the CHA2DS2-VASc is 2 or greater, say 3 or 4, then we use anticoagulation. It's these intermediate risk CHA2DS2-VASc1 that are really tricky. So a Norwegian group, actually one that I visited this fall, they have a very nice database analysis looking at the question 1, so what is a stroke and bleeding risk in AF patients with and without anticoagulation who are in that CHA2DS2-VASc1 group? Second question is, what is the risk of stroke in non-anticoagulated patients who with and without atrial fibrillation? Now, their methods included a big Norwegian database of over 1 million individuals in which they found 34,000 AF patients which fit the criteria. They followed these patients for 8 years or until they had an ischemic stroke or a hemorrhage or whether they increased their CHA2DS2-VASc score or the study ended. The authors calculated the 1-year incidence rates and events, that's per 100 person years. They then did Cox regression to provide adjusted hazard ratios, and they had 4 big results. First, among those patients with AFib, the ischemic stroke rate was 0.51% person year who in anticoagulation users, but it was double that, 1.05% per person year in non-users. So the adjusted hazard ratio of anticoagulants is a 0.47, so a 53% reduction in a reduction of ischemic stroke. Now, what about intracranial hemorrhage? The intracranial hemorrhage incidence rate was 0.28% per year if they're on anticoagulants, 0.19% per year in non-users. So really, think about it, not much difference there. Third finding, oral anticoagulation use was associated with an increased risk of major bleeding. The hazard ratio there was 1.37, but you balance that against a lower risk of the combined outcome of stroke, bleeding, and mortality. And here, that sort of net benefit is 0.57. So even though it bumps the bleeding risk a little bit, you still get that net benefit at CHA2DS2-VASc 1. Non-anticoagulated individuals with AF had a higher risk of ischemic stroke compared to non-AF individuals who had the same CHA2DS2-VASc risk profile, and the hazard here was 2.5. So you take the same CHA2DS2-VASc, you add AFib, and the risk is 2.5x greater, and that's a lot. So my take-home points. Databases like those in the Northern European countries, I think, really help us. Yes, they are still observational, and a clinician has to make the choice to treat or not treat, so causal inference is going to be challenging. In this case, they studied the most vexing population of AF patients, those with a CHA2DS2-VASc of 1. These are the toughest decisions because you don't want a devastating stroke, but you also don't want to commit a relatively young person to decades of oral anticoagulation. The mean age of these patients was only 61 years, so that's a long time to take oral anticoagulants. And the main findings, I think, the yearly stroke rate was 1% with AF and no anticoagulation. Patients on anticoagulation had a 0.5% risk. So we can tell our patients, at least if we go by this database, it's a 53% reduction. There was not much cost in terms of intracranial hemorrhage, as both remain super low and at rates less than 3 in 1,000. Major bleeding might go up by a little bit, by 37%, but when you look at the net benefit is still there. And finally, the rate of stroke on those CHA2DS2-VASc 1 patients not on anticoagulation was 2.5x greater than those similar risk patients without AF. So in these patients, AF is a big risk, and that makes sense, right? Because when we think about Andrew Foy's picture, those 4 circles, those 4 domains that affect treatment effect, at age 61 and 1 risk factor, AF is going to substantially increase the risk of stroke because there are so few competing risks of stroke. That's different than older patients, say an 85-year-old who has tons of stroke risk factors, and when you add in AFib incrementally, it may not be as an important increase in stroke risk. So that's it for this week in cardiology. In fact, this is the last podcast of 2023. It's been a great year. I'm really grateful for your support and for listening. And the thing you can do for us is go to your podcast app, give us a rating, write us a brief review, go to the heart.org website, write us a review, tell us what you think, what you like, what you don't like, and give us some feedback. And we will see you the first week of January. And I hope everybody has a good holiday time. This is John Mandrola from the heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the heart.org Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.